we are switching to the next session. Before this, I would love to tell something. It was scheduled to be a webinar from USA by none other than Dr. Y. Chandrasekhar, Editor-in-Chief, JACC Cardiovascular Imaging. Day before yesterday night, he called up and said that he will not be able to be present in the webinar live because of some family problems. And he sent us his recorded thing through the cloud. At first I thought of removing this from the schedule, but since this time we have upgraded to an imaging conference and this was on the present status of CT coronary angiogram, it was so well said a webinar that I thought that it will be selfish for me not to share with you all. And for that same reason we are sharing the recorded webinar. If at any point of time you feel that this should not continue, I will stop it. Thank you so much. May I call the chairpersons on the dais, Dr. Mahesh Kumar Chaudhary, Dr. Bikash Bhattacharya, Dr. Amit Kumar Ray.
Two different sections. The first part is dealing with coronary artery disease. We'll talk about diagnosis of CAD and estimating severity of stenosis, something we do day in and day out, and this forms the bulk of our diagnostic modalities. I'll also touch a little on diagnosing ischemia with CT, but CT has not reached absolute operational threshold in this area. There's some exciting data that I will share. We'll talk a little bit about characterizing plaque, but that's an emerging indication. In the non-coronary artery disease realm, we'll talk a little about assessing valves, both native and prosthetic. We'll talk about assessing left atrium and left atrial appendage. And if time permits, we'll talk a little bit about peripheral and structural intervention CT. It's very important before we proceed further to understand the difference between stenosis and risk. Stenosis is a physical concept, whereas risk is a calculated concept. If your question is to estimate risk, you have no better test than a coronary artery calcification. Here are 4 examples of coronary artery calcium. The software will allow us to color calcific areas and quantitate it. Here is an example of an artery without significant stenosis, but there's a speck of calcium here. Even though there is no obstruction possibly in this patient, the very fact that there is calcification means he has coronary artery disease irrespective of any other testing. And even though there is no obstructive coronary artery disease, he is at risk for future events based on coronary artery calcification. As the calcification increases or the location becomes more and more proximal, the risk of future events increases significantly more. Compared to any other classification system, including Framingham risk factors or any other way of classifying risk, coronary artery calcium is turning out to the best test that you have. You can also assess risk based on how the coronary arteries arise, and here is an example of an anomalous right coronary artery going between the aorta and the pulmonary artery, and many people believe this confers a high risk situation. The other question we need to answer is degree of stenosis. Here is an example of a great picture of a coronary artery disease as evidenced by coronary artery calcium, but no significant stenosis. This patient, even though he doesn't have significant stenosis, is at a higher risk because of the presence of coronary artery calcification. CT gives you some great images in non-stented as well as stented arteries, and you can see non-obstructive coronary artery disease, moderate stenosis and severe stenosis demonstrated very well. You can also look at plaque morphology. You can see here a moderate stenosis, which in the olden days we would say nothing needs to be done, it's not high risk, is now proven wrong by coronary artery CT, where you can see high risk plaque, low attenuation plaque, which often corresponds to necrotic core, positive remodeling. All of this confer significant degrees of risk. So how do you characterize risk in asymptomatic subjects? This is a huge question, probably a bigger question than diagnosing coronary artery disease, since there are so many more people who are asymptomatic and at risk. This is one of the most seminal papers in this area, and for those who have not seen this paper, they should look at Robert DiTrano's paper in the New England Journal of Medicine. This talks about the effect of coronary calcium in a prospectively studied population called the MESA study. And it showed very nicely in asymptomatic patients without any coronary artery disease, a zero calcium essentially means nearly no events on the follow-up of about 5 years. Any degree of increasing calcium, 1 to 100, 100 to 300 or more than 300, shows a graded increase in risk of death, MI and stroke. There is another way of looking at coronary artery calcium, that is, how much warranty do you get if you don't have coronary artery calcium? I have shown you a number of different classifications here, but if you just concentrate on the Framingham risk score, if you don't have any coronary artery calcium, and even if you are in the intermediate risk, you have a 15-year warranty of not having events defined as time to greater than 1% a year risk, compared to those intermediate risk patients with any degree of coronary artery calcium. You can see right away that even in the low risk patient, who normally would not have events over the next 15 years, having any calcium more than zero significantly drops the risk-free period to 4 years from 15 years. You can see the same thing based on ATP3 classification by gender and by age. All this tells us it's an extremely powerful risk factor. How about presence of plaque if there is no calcium? Here is an example of a coronary artery with moderate stenosis, which again we would in the olden days say it's not of any great risk, but the presence of a soft plaque here, which is not normally seen on angiography but can only be seen on CT, suggests risk. And here is an example. If your CAC is 0 but you have a plaque, you are no longer a low risk, you are not below that magical 1% a year event rate, you exceed that, suggesting the presence of plaque adds to the presence of calcium. How about coronary artery stenosis? We've looked at coronary artery calcium, but how does that relate to coronary artery stenosis? And it's intuitive that a coronary artery calcium of 0 usually means you have a 80+% chance of having a normal CTA. But there's a small chance that you have obstructive coronary artery disease. As the coronary artery calcium increases, the chance of having a normal CTA decreases, and this has led to certain groups in Europe to use coronary artery calcification as the first test before somebody is subjected to a stress test. If the person has no coronary artery calcification, many people are foregoing doing a stress test even if the patient has chest pain. Similarly, with increasing coronary artery calcification, the chance of finding obstructive coronary artery disease increases significantly. Thus, CT gives you two different ideas. It tells you risk from coronary artery calcium, and then it tells you stenosis. So what testing should we do for diagnosis? It depends whether you want high sensitivity or high specificity. If your gold standard is invasive FFR, the test that comes closest to invasive FFR, both in terms of sensitivity and specificity, is CT-FFR. Plain CT itself has great sensitivity but very poor specificity. On the other hand, looking at transluminal attenuation gradients has high specificity but poor sensitivity. Other tests fall in the middle, and you will be surprised that invasive angiography or IVUS has modest sensitivity and modest specificity. So here are some examples of what you can see on CT: a normal LAD, tight proximal LAD lesion, normal circumflex, beautiful pictures, tight circumflex, tight RCA, and a great picture of a left main stenosis which is proven with angiography. You can see how nicely the details correspond to angiography. But why is CTA not recommended as first line? None of the guidelines, the HACC or the European guidelines, recommend CT as the first initial test. And why is that? Here is an example. When you compare CT in the yellow with CT-FFR or invasive angiography in the cream color, you will see that CT has great sensitivity but low specificity and low positive predictive value. And if you take one message from this talk, it is CT is good for ruling out coronary artery disease, but not so good for ruling in coronary artery disease. That's improving, that's changing, but at this stage, its negative rule out power is bigger than its positive rule out. And that's why it's often recommended for low risk individuals to rule out coronary artery disease. How about diagnosis of ischemia? We have seen CT is not good at diagnosing severe coronary artery disease in the 70-80% range. It does very well on the negative side and very well on the 90% side. How can we improve that? And the test to do that is CT-FFR. This is a test acquired from standard CT images where mathematical modeling is used to predict the severity of stenosis. Here is an example, an invasive angiogram. Most of us would say, this is a CT, most of us would say there is a significant lesion here. Angiography seems to convince us that there is a fairly significant lesion here. However, CT had suggested there is no significant FFR lesion, and indeed when FFR is done it was 0.86. On the other hand, in this artery there is a lesion here, there is a lesion here. This was thought to be moderate, however CT FFR said 0.71 and indeed invasive FFR said 0.74, suggesting that this is a great test to diagnose severity of stenosis. Very interestingly, it's not affected by severely calcified vessels, 0.74 by FFR CT, 0.71 by invasive CT. Diffuse CAD, again, they match, and in intermediate lesions. You can also not only predict pre-stenting FFR, here is FFR CT corresponding to invasive FFR. You can also predict what would happen if you put a stent here. Here they predicted after the stent the FFR would be 0.8, and indeed it was 0.88 after stenting. And you can do the same thing, predict what will happen after bypass surgery. So where is CT useful? This is a very famous study called the platform study, which looked at non-obstructive CAD, obstructive CAD, and showed in a big trial that Patients scheduled for invasive angiography, if they take a detour to the CT lab, you can change your decision making significantly. So here is a group of patients who were scheduled for angiography but had a FFR CT before they had an angiogram, and here is a group of people who went straight for invasive angiography. You will notice two things. The patients who went and had FFR CT, they ended up with nearly 60% less need for invasive angiography, and among the people who went for angiography, non-obstructive CAD, that means where an angiogram didn't make a difference, was significantly reduced compared to people who went directly for angiography, where 70% of the angiographic studies did not really result in anything useful. They ended up having non-obstructive CAD. So FFR CT will act as a great gatekeeper for such studies. How about CT perfusion? This is one area where we can even diagnose ischemia with CT. So you can diagnose anatomy, FFR and ischemia. And here is an example of a patient with no ischemia on CMR perfusion, no infarct on late gadolinium enhancement, and no ischemia on CT perfusion. Whereas here is a patient with inferior septal ischemia, no infarct on LGE, has ischemia here, the purple and blue area, and if you have an infarct, you again have ischemia. What are non-CAD indications? It's great for looking at prosthetic valves. You can see how well the valve closed. These closing and opening angles have been published, and you can quickly see how a valve is behaving. Here is an example courtesy the Cleveland Clinic folks about a leaflet which opens well while the other leaflet has not opened well. You can make great diagnosis. It's also useful in a condition called triple rule out, where you can exclude coronary artery disease, dissection and pulmonary embolism in the same scan of patients coming to the ED with chest pain. Among electrophysiologic procedures, it has a lot of utility, and one of them could be diagnosing pulmonary vein stenosis after pulmonary vein ablations. Left atrial appendage is a useful indication. Here you can see when you give dye, there may be a clot in the LA appendage. The trouble with this is you don't know whether the dye did not yet reach this, or is this a real filling defect, and that's why we have to do a second scan a few minutes later, and then it shows the dye filling, yet there is a space occupying lesion consistent with LA clot. There are some new diseases that are being diagnosed. Here is a status post TAVR valve at pathology which showed thrombosis, and if you go back and looked at their CT, you see this CT lucent area. These correspond to fibrin clots, and this is becoming a very important problem as evidenced by Raj Makkar's paper in the New England Journal of Medicine last year. You can give anticoagulation, it appears these disappear after that, and so the CT might be a great way of following such patients. You can also look at aortic stenosis. One of the big advances of CT here has been traditionally for aortic valve continuity area, you use the outflow area assuming that to be a circle, but CT has shown very often it's not a circle but an oval, and you can get the outflow area very well. If you substitute CT outflow area instead of echo outflow area and calculate aortic stenosis, very often the valve area appears to be higher, which suggests that echo is underestimating the valve area. Lastly, in the aortic stenosis field, very often you get patients where you don't know whether the valve area is severe or not severe, And aortic valve calcification, just like we did coronary artery calcification, is helping us. A aortic valve calcification value of more than 1200 in women and 2000 in men seem to suggest severe aortic stenosis, and as you can see, as the calcium goes up, the incidence or relative risk of bad outcomes happening also goes up. So when you have a doubt and you have a situation where you don't know how tight the valve is, this may work very well. So what is the summary of CT? It depends on the question. If you want to find stenosis, CT angiography is a good bet. If you want to find ischemia, you can look at myocardial perfusion with PET, SPECT, or maybe in future with CT perfusion. Stress echo and stress AMR, of course, are very good. If you want to find stenosis causing ischemia, you can do FFR CT non-invasively, and if you want to find risk, you need to look at coronary artery calcium and plaque on CT. What are the essential nuggets for CTA? As I said, it's good sensitivity but low specificity, so it's a good gatekeeper. It reduces the rate of people going to catheterization and finding normal coronary artery, and then it helps you in decision making. What are the limitations? It's not very useful or difficult in patients with heavy calcification, small stents, dye allergy, and renal failure. It's difficult to do with atrial fibrillation and fast heart rates or irregular rhythms. Morbidly obese patients, patients who cannot hold their breath, are not good candidates. Generally contraindicated in non-STEMI or a high probability of STEMI because you are going to do a cath anyway. And in young women, radiation may be an issue, but this is coming down. Where is FFR CT in this picture? It improves the accuracy of conventional CTA. It can provide site-specific values, so if you have 2 or 3 tandem lesions, you can find out FFR in each of those segments. It's obtained from standard studies. It's not affected by calcium. But one of the problems is even in the best centers and in multinational studies, 10 to 20% of the CTs are suboptimal. And at this time, you have to send this out to the company, and it takes about 6 to 12 hours for the report to come down. So there was an overview of what CT is today, and I will take some questions. Thank you.
Is a well-valued deliberation of the multimodality imaging techniques, particularly CT angio, and also about FFR CTA, and he is deliberated particularly
Good afternoon. It's a great pleasure indeed to be among friends again and deliver this talk on coronary.
Deliberate specifically on the calcium scoring, both on the coronary artery and the aortic valve also, and the virtual FFR CTA, and we can diagnose the particular lesions where we can treat the lesions just invasively or non-invasively. And this deliberation, the multimodal imaging technique is much helpful in just diagnosing and just shortening the window where we can go to invasion, where we can do non-invasion. Just any comment from the audience regarding this? Professor Mohan, any comment regarding this, about this non-invasive FFR CT and calcium scoring?
Based on these CT findings, CT coronary finding, if anybody send this patient to the surgeon straight away without doing the conventional angiography for the CABG, it is a question to everybody. Based on only the CT coronary findings, if suppose get a triple vessel disease with, suppose there is FFR is low, and send the patient straight away to coronary artery bypass graft surgery without doing the conventional angiography?
Not, yeah.
Why? Why not? Still correlating well. He has shown is still correlating with the FFR before and after the angioplasty and all these things.
You must have followed that the negative predictive value is high, but the positive predictive value is still low. The FFR CT specificity is higher than normal CT angio, but still it has not reached a gold standard for coronary angiogram as a marker for cardiac surgery. It will take some time. It's still in the process of evolution.
There is no sufficient literature to substantiate FFR CT. So we have to wait for another couple of years to substantiate.
I have gotten a comment for calcium scoring. In recent time, 2016, we have went through the NICE guideline draft. It has not finalized yet, which has given emphasis on calcium scoring. If a patient has if a person has a pretest probability of less than 35, they are suggesting that they should go for calcium scoring, and if the calcium scoring is less than 100 agatron, then this patient can be followed up. So NICE guideline in recent time, it has not finalized yet, but they have given much emphasis on calcium scoring and CT angiogram. Even with patient with stable angina, they have suggested that if the calcium scoring is more than 300, then this patient should go for CT angiogram. Stable angina. If CT angiogram shows the lesion, then the patient can go for lifestyle modification and other thing. But before going for intense lifestyle modification, he has to be confirmed that he has got something in the coronaries.
Thank you very much.
Thank you. We are closing the session.